Well, I think I'll go ahead and get us started. I'm Dr. Jane Mahoney, and I'm the director of the Dissemination Implementation Launchpad. And welcome to our Dissemination Research and Implementation Science monthly seminar. Today, we are having our seminar focus on Introduction to D&I. And I'd like to introduce Felice Resnik, who is an implementation scientist at our Dissemination Implementation Launchpad here at UW-Madison ICTR. Felice is passionate about D&I science as a bridge to connect science to practice and to extend the impact of research. Her work focuses on designing and developing knowledge of practices associated with successful dissemination and implementation of evidence-based interventions. So welcome, Felice. I will turn this over to you. Thank you so much. For questions, you can put questions in the chat. We'll also have a lot of time for Q&A afterwards. So thanks.
Thank you, Dr. Mahoney. As Dr. Mahoney shared, I am an implementation scientist in the D&I Launchpad at UW-Madison, and I'm excited to join you all today to provide an introduction to dissemination and implementation science that from here on out I'm going to call D&I. As part of this introduction to D&I, it serves both as an intro in this DRISS seminar, but also for folks who are planning to attend our D&I hosted short course that will be happening in about 3 weeks. If you are planning to attend, we're really excited to see you there. We have really interesting guest speakers, and we think we will all learn a lot. They're really engaging, and we've planned some new sessions to really build on all the learnings that we've had the past few years. Or if this is your first time, we have really cool ways now of really laying the groundwork for getting everyone interested and excited about D&I and how it applies to your work. If you have not registered already, I encourage you to go to our website to register for the event. It is go.wisc.edu/shortcourse2023. And I believe that has been put in chat. I also want to thank our funders, because without them, both this presentation and the short course would not be possible. So for our agenda for today, I'm going to go over what is D&I research. I'm going to talk about the introduction to what it is, why we use it, and how we can integrate it into our approaches. And then I'm going to spend a little bit of time talking about design for dissemination. What are some best practices in dissemination science that we can use when designing our interventions? I'll share some additional resources, and then we will have time for questions at the end. If you have any clarification questions throughout, you're welcome to put those into chat, and if one of the facilitators could bring them to my attention, I'm happy to stop and answer any questions that are clarification before we reach the Q&A section. So to begin with, there's this focus that many of us have heard of that we need to close the gap between research and practice, that the US spends a lot of money, about $194 billion annually on health research, yet it takes 17 years on average to translate just a small amount, 14% of original research, into benefits for the public. So we spend all this time learning about what works and how it works. And yet, when we look at the impact on the individuals we really care about, we're not seeing that happen for the majority of that work. And so it's really important that we think beyond publication to really how we can close that gap so that it's faster, and close that gap so that we have more impact, and trying to think of alternative ways to disseminate research and implement findings into practice to impact outcomes we care about. Also, oftentimes, as well-intentioned researchers, we develop interventions and tools and innovations that we believe will help impacted users, that we see this problem, this gap in the literature, or maybe from talking to one or two folks, this idea will occur to us, and we develop an intervention that we think will solve the problems. Oftentimes, when that happens, we end up in a situation where we're maybe building something without understanding the context to which we are building it for. So what happens if we build an intervention and no one comes? Or if we build this intervention and only some sections of the population come and we're not able to have as much impact as we are looking for? So it's really more than just building an intervention to figure out to fill that research gap, and really about building an intervention or an innovation to optimize the benefit of it, so that we think beyond why it matters and really talk to all the impacted users to think what's appropriate, making sure that they have the resources to do it, that they have the proper education and training, that we're bringing them the resources if they don't have it, so that if something isn't too expensive for them to actually implement it. How do we make sure that it can scale and sustain over time when the research process is over? And make sure that that's the thing that the impacted users actually want. Now, just because it closes that gap, it doesn't mean it's the thing that the folks want or the thing that will fit best in the community or in the context to which we are implementing it. And so D&I science is really here to answer those questions. How do we decrease the time it takes to get research into practice? How do we bridge the gap to supply and have these methods and strategies to support the use of so that it increases the success of implementation, dissemination, and sustainability? And how do we bridge the gap to translate evidence-based practices into a real-world setting? So we're having that real-world impact for those folks that can use these interventions or these innovations the most. Not just that we're doing the research to publish our next paper, to maybe have some of us think about it for the literature. How do we really use D&I science to increase the likelihood that we will have success of implementation, decrease that time, and have that impact we're looking for? Before I get really deep into this, I want to make sure that I am clarifying any terms that I'm going to be talking about today, because the world of D&I science is somewhat filled with jargon. And I find that the more I spend time in it, the more I realize that we can really simplify this by just making sure we are all on the same page at the beginning about what we're talking about when we talk about D&I science. So the first thing is talking about what is dissemination. I feel like most folks who do research hear about dissemination from a dissemination plan that we're told to include at the end of our grants. How are we going to share those results? And that is definitely one way to think about dissemination. But I encourage, and in the science of D&I, we encourage folks to think about dissemination in a more broader sense, to think about it as the targeted distribution of information and intervention materials to a specific public health or clinical practice audience. And not just one public health or clinical practice audience, but whoever might be interested in receiving this information. The second key term I want to make sure we all understand is implementation. Some folks think about implementation as just the act of doing an intervention, which is definitely one way to think about it. How we take an intervention and actually implement it into practice. How do we do it? But in implementation science, we're really thinking about how do we use strategies to adopt and integrate evidence-based interventions and change practice patterns within a specific setting. What are we actually doing to make sure the intervention works well for the users of the intervention? And then finally, sustainability. How do we think about when change has become an integrated or mainstream way of working rather than something added on? How does it become part of our core practice or something that any interested user could have access to after our research is over? How do we make sure it really does bridge that gap into practice? And this all comes together with that core goal of D&I research, which is to increase our understanding of how to effectively get evidence-based or evidence-informed strategies, interventions, programs, whatever that thing is, into practice. So those are kind of the core pieces of D&I science and what I mean when I talk about them for this presentation. The other group of terms that I want to clarify fall under when I talk about a theory or a framework or a model. So here's the thing. All three of these are different. They mean different things. But when we talk about them as D&I scientists, or when I talk to folks who are interested in D&I science, we're oftentimes using them interchangeably, which is pretty confusing. But I want to make sure that we all acknowledge that they're different things. A theory is a set of analytical principles or statements designed to structure our observations, understanding, or explanations of the world. Oftentimes you'll hear about a theory of change. What are the structures or understanding of what will lead to a change because of our intervention, or the theory of action? You then have your frameworks, which are strategic or action planning structures that provide a systematic way to develop, manage, and evaluate a research project. I like to think of it as a map. What are the different pieces of our process? What are those different steps that we can think about to guide our work or our implementation of an intervention? And then finally, we have a model, which is a description used to simplify a phenomenon. Often, for simplicity, these kind of collectively involve both theories and frameworks because it really is about simplifying the process. That being said, for today's talk, I oftentimes will just say a framework, and that will be what I'm referring to, but I will try my best to indicate whether I'm talking about a theory, framework, or model when I'm talking about each of those within this talk. And then finally, the last key terms I want to discuss are implementation outcomes and implementation strategies. Implementation outcomes are what we're measuring at the end. How will we know that we're having impact? And there's different ways we can measure impact, and I'll give some examples of those earlier in the next few slides. But it's really the effect of deliberate and purposive actions to implement new treatments, practices, and services. How will we know this thing worked? Who are we trying to impact, and how will we measure that? Whereas implementation strategies are those methods we're using to enhance those outcomes. How are we going to make sure that we are reaching the correct folks? How are we going to actually make sure people are learning the intervention that we are trying to do? And so these are the key terms that I'm going to start using throughout this. And I wanted to make sure I spent time early on defining them, because otherwise sometimes I found for myself that I got caught in the jargon and lessened the goals of the process. So now I'm going to tie this all together using a framework by Curran et al. 2020, which is really just implementation science made too simple. And I love this because it really does make it almost too simple. The intervention, the practice, the innovation is the thing. That is the goal of implementation science, is taking that thing and figuring out how to make it work. And the thing that I will talk about now is going to be an intervention, but you might have something in your mind right now for an innovation or an intervention that you're working to implement, or an idea you have for one. And maybe you can just jot that down. What is the thing you're going to have front of mind as you are going through this talk and as you attend the D&I Science short course? Is it an early stage idea that you want to pilot? Is it something that you've collected that pilot information about, that you already have that effectiveness information and you want to figure out the best strategies? What is that thing? And jot it down so that you can continue to go through this process and have it apply to your own work. The second step, which many folks are comfortable with and that they have done in a lot of intervention research, is effectiveness. It's looking at whether that thing works. If I do a clinical trial in my confined setting, how will I know that that thing works? Whereas implementation research looks at how best to help people in places do the thing. How do we get it so that in the real world, we can make sure that different hospitals, different community settings, different adopters or facilitators are able to do the thing? How do we help people do that? And when you're starting to brainstorm these ideas about how you can best help people do the thing for whatever project that you wrote down at that beginning, those things, a lot of times, oftentimes, I think the first thing people think about is education, right? We're going to have a workshop. And that workshop is known as an implementation strategy. Those are the stuff we do to try to help the peoples and places do the thing. And there's a lot of strategies. I'll discuss more of them later on, but really can be synthesized to how are we going to do the thing? How are we going to help people do that? And then finally, those implementation outcomes. How much and how well do folks do the thing? Are we reaching the people we want to be reaching? Are they doing it with fidelity? Are they continuing to do the intervention 6 months later? Are they maintaining it? What are those outcomes that matter to us as researchers, but also to the folks who are going to be receiving the intervention? And how are we going to measure that? This is implementation science made too simple. Like really each piece of this can be distilled down to this idea of the thing and how we make sure it works and how we helping people do the thing. What are those stuff and how do we measure it? And I know that sounds too simple because it is, but if you can really gather these basic ideas, then we can start to study the different pieces of it. I found this task really helpful, especially early on when I'm trying to think through like an early consult or pilot about a study. And what am I hypothesizing will happen? What are those things? And I can start jotting down some notes for each one of these. It might not be right, but it will help me frame what I'm starting to think about. Another way to think about this, and now I'll provide kind of an example, is we can have our evidence-based practice. So an evidence-based practice is the what of that thing. So for example, an intervention that I have had the pleasure of working with Dr. Heidi Brown on is Mind Over Matter, Healthy Bowels, Healthy Bladder, or MOMS, which is a community-based program that empowers women to improve their pelvic health in order to reduce or prevent incontinence in older women. Dr. Brown has designed and tested a workshop that teaches skills to control incontinence symptoms through lifestyle changes. And now she's working to adapt MOM into an electronic program. And so she wants to know, we have this thing, we have MOMS. What are the stuff we can do to deliver it well? What are those things? And those things are the implementation strategies, the how of that stuff. And some of the ways that she thinks we can enhance how we're implementing it is through educational meetings, that we can conduct meetings with the different facilitators of the program to help tailor it for the virtual setting, and also to help teach them how to implement the program with fidelity. We're also having meetings with advisory groups in order to get some feedback about potential adaptations, really trying to figure out how we can figure out that stuff, those strategies to make an impact, to really implement this thing well. And then finally, we're looking at outcomes, the benefit. And for this program, and for all programs really, you do not need to look at all of these outcomes. The implementation outcome framework by Enola Proctor is very helpful to give a guide of all the things you could look at. But just because you can look at this does not mean you need to look at all of them. And so in this case, we looked at ones that we thought were the most relevant to the questions we wanted to ask. And we wanted to know things around implementation outcomes related to fidelity. Can this be done by the trainers with fidelity? We wanted to know things around acceptability for the folks receiving this intervention. Are they happy with it? Is it acceptable? Can they do it? Also for the trainers, is this acceptable for them? Doing something virtually is different than they were used to. And how do we make it so that this is an acceptable intervention for them? We also were looking at outcomes related to patient-centeredness. Healthy moms is related to something that tends to have some stigma. We want to make sure we were centering the patient in these discussions, that it wasn't too medical, that we were really understanding the needs and really centering the patient in this work. And so that they felt that we were truly valuing their impact and their input. And then finally, we were looking at symptomology, really like the effectiveness of this program. Does it reduce symptoms of incontinence? We were looking at that symptom improvement as part of client outcomes. And so that's really what we highlighted in this. But again, how you break that down really comes down to the question you're trying to ask. Also, to kind of highlight something that we are going to be talking about in the short course, and just kind of to give like the most basic idea, you can take everything I just said and put that into the implementation research logic model, which J.D. Smith is going to get into more detail about during the short course, where you can think through all those pieces and have this be a guiding frame for your study, or use it as a way to like make sure that you are understanding each one of those pieces, seeing where you might have gaps, or to help you plan your next study. What is working, what's not working? And so I just wanted to bring this up today, but if you are interested in it, make sure you attend our short course so that JD can help us really apply this to our work. The next thing I want to talk about is the thing that I find most people come to me just like overwhelmed with, which are D&I models and frameworks. They come because they want to do a D&I study, or they are trying to apply for an implementation science grant. And the first thing that comes up is, I need a framework, or I need a model. And how do I go about picking one? I did a Google search and 18,000 popped up. And there are plenty of websites online that will help select one or give overviews of them. But I like to think through a couple of tips when selecting a model, because then when I'm online looking at all of them, I can think whether they are relevant for me, my project, and the outcomes I'm interested in. So the first is, how do I select a model? What are these tips? First, think about the aims of the project. What are my research questions? Am I trying to figure out, does the intervention work? Maybe I already know the intervention works, and I'm trying to figure out how I can overcome barriers that are happening in my context to have real world success. Or maybe I've already done that, and I'm trying to figure out different strategies that can work. What are my research questions? Because that will help me figure out what to narrow in on. The second is the focus of change. Am I focusing on individuals, organizations, or systems change? Because different models or frameworks focus in on different levels of outcomes. Some of them really are focusing on that individual change, whereas some of them are more systems level. Are we having bigger picture impact on a whole hospital system or on a policy level? And that will make a big difference. Oh, the third thing here is context. And context is trying to understand where this intervention is happening. What resources are available in the setting I'm trying to implement this intervention in? And once we understand the context, we can see if we're focusing on just that small inner setting, and that will help us evaluate which model to select. Or are we trying to do a larger context, which might be more, we might want to evaluate broader, and that will help us focus on that. The fourth thing I want to consider is whether I am doing this evaluation or measuring my outcomes once, twice, longitudinally, iteratively, because different types of models are more easy or difficult to adapt to those different timing of when you are trying to measure your outcomes. And then finally, how will it be measured? Some most models that I recommend, you can use qualitative or quantitative or mixed methodologies in order to measure outcomes. But certain models will have different measures that can be used or should be used when implementing and using those to frame your study. And so if you are thinking you want to be having focus groups, you might want to be looking at one that has a little bit more of a loosely outlined frame so that you can adapt it better to your context. Or if you're looking at something that you really want to just focus on acceptability and having a quantitative measure of that, there are ones that will align to that as well. So after you've jotted your notes down around that, this is really just reiterating it, but I really think the next step is really getting back to that question of why are we doing this? What are those key questions? And then that will help you pick your model, whether you want it to be more flexible or loose, if you're looking at dissemination or implementation, and which level it's happening at. Just those fundamental questions of picking your model or framework. I put up one tool that I've referred a lot of people to, but we also have many tools on our resources on our website, which we'll have at the end, and perhaps one of our facilitators can put in chat the link to our webpage on the D&I team, where we have plenty of resources for folks to check out. Or if you're a part of UW-Madison, we're happy to have a consult to help direct you and can talk about this at Short Course. But it can be overwhelming because when you do go on this website, even if you have the way to answer each one of those checkboxes that you see on the right, it's still going to come back at you with many questions. So knowing what you're trying to answer will help really simplify or guide you towards the right framework. I'm going to give 2 examples of how we can pick frameworks or models of ones that we've used in the past that I highly recommend for folks to use, that I have found to be really useful for many different types of implementation projects at many different stages. So the first is the CFIR, the Consolidated Framework for Implementation Research. And the second is REAIM, which stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. I put the citations for all of these here, and these all can be found on our website, but if you want to go back to the primary sources, these are the ones that I often tell people to go to. The Consolidated Framework for Implementation Research, I'm going to put a caveat here that the update that was done in 2022 is excellent. The resources on the CFIR website have not been updated though to them. So I'm still using the original CFIR with my examples, because in talking to Dr. Damschroeder, or talking to Laura Damschroeder, she has said that there's still room for tailoring of the new one, and also that we're still kind of learning how to apply it. But that being said, I still really recommend it. I think the updates to it really build on some of the things we have learned about implementation science in the past 10 years or 15 years since this was originally published. The consolidated framework is also nice because it's a consolidated framework, meaning it includes constructs from many other theories and models. So it includes focuses on the outer setting or the inner setting, and makes it so that we can overcome some of those gaps that the other theories have, and make sure that we're being more systematic in the language that we're using across those theories, to really make sure that we all know what we're talking about when we talk about the different types of context. This is also a determinant framework, which is really good for examining facilitators or barriers, really understanding the context to which an intervention will be used or could be used. Really figuring out what determinants, what factors are happening in that context at the different levels, and how they might impact, for good or for bad, implementation of the innovation of the thing. So an example of how we have worked with researchers to use the CFIR is a study by Dr. Fiore, who is at the Tobacco Research Institute at UW-Madison, and they utilize the CFIR to assess potential barriers and facilitators to implementing striving to quit across all 5 domains of the CFIR. And the interventions, too quick. Striving to quit is an intervention that focuses on individuals who are trying to quit smoking, hence the name, and these women are typically pregnant or recently postpartum. They're implemented this is implemented in a community setting, which is important to know, and also it is implemented using individual staff to facilitate the program. The CFER is wonderful for this type of project because it allows you to look at each one of those folks who are involved, the different levels of individuals, and also looks at all the things that might impact implementation. Things at the inner setting level, so the very specific climate or culture or impact of that one setting, that one location to which Striving to Quit was being implemented, that one organization. And one of the things that was heard in those focus groups that we're having with the facilitators of Striving to Quit was that this intervention was really compatible with that inner setting climate, that the intervention fit better with existing workflows so that nurses could bring the topic up, but leave the hardcore counseling to the professionals. So there was less paperwork for that coordinator, which fit better with that inner setting of the organization. Their current workflows of what was working for them or not working for them, and understanding that was really helpful to understand if Striving to Quit would be a fit for the organization or if it should be adapted again. The other level that they were considering, well, they considered all of them, but another level that they considered was the outer setting. And those are bigger, larger macro system, often things that impact implementation. So in this case, it was external policy incentives that kept coming up. There was a reduction in state aid to counties. And so they were explaining that because of that, shorter interventions like Striving to Quit are needed. That because of reduction in available funding, they needed programs that were shorter and less expensive. And so this would be a fit for their setting. Additionally, the intervention Striving to Quit, they felt would be a fit because it was adaptable, that you could make it less complex than some of the other interventions they had tried to implement, because they could add referrals to other organizations that they worked with, such as Wisconsin Women's Health Foundation, instead of and adapting it to fit with the context they were in, instead of it having to be exactly the way that some of the other ones they had used in the past. And then finally, in talking to all the individuals involved, they found that the self-efficacy of the staff, how confident the staff was in implementing the program, was important. And they found that the staff found that Striving to Quit was something that they felt really confident introducing to their clients because they felt it was less complex, that the education around Striving to Quit was easier for them to understand and more aligned with what they felt they had the ability to do, which made them more confident to provide it. And additionally, they talked to the participants in the program, and they saw that the participants at that level had a lot of mental health needs, poverty, stressors, etc., and that they felt that this was a good fit for them, that it was really meeting the needs of the recipients and the recipient outcomes, and that was a fit for them as well. And so it's really a nice way to organize and understand the barriers and facilitators that might be happening in the context at many different domains and levels for an intervention. In many ways, this has really worked best to understand that context, either if this really works well or ways that you could adapt it going forward. So it can be used at many different stages of an implementation process or project. And there are many other different examples I'm happy to share at another time if people have additional thoughts or questions about this. Another framework that we often use is REAIM, which can be used as a process framework, but honestly, most of the time I use it as evaluation. And I will say that Glasgow et al. Have their PRISM framework, and they will encourage you to use it for process. But for ease of an introduction, I'm going to speak about it as an evaluation framework. So as I mentioned, REAIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. And which part of this you focus on depends on those questions you are trying to answer. But it's important to consider all of them when you are implementing or adapting an intervention, because there are pros and cons that you might impact one of those metrics in order to change another. And so just having those in the back of your mind, what might happen to each one of those based on different strategies or alterations or adaptations you make. I also want to call out a recent extension of the REAIM framework by Shelton et al. That focus on enhancing sustainability and promoting health equity. There are excellent thought questions to think about how you can measure these different aspects to promote health equity and taking that lens to your work. So now to extend kind of what I'm talking about for each one of these 5. The metric of reach, one of the ways that we can measure it or think about it is, are we reaching our intended audience? Are we reaching the folks who could use it the most? Are we only reaching those who are going to be somewhat easier to find or who have been the most vocal in wanting this intervention? And have we made an effort to reach historically underrepresented and marginalized individuals? Those are some of the ways you could think about or measure this metric or measure this aspect of reach. The second is effectiveness. Is the intervention effective in practice? So does it work? But really, one of the things to consider is it working with all groups who receive it? In order to make sure we're not accidentally exacerbating health disparities, we want to think about subpopulations within our work who might be having differential effects of an intervention. So by thinking first about how we're reaching or not reaching different groups, we can then think about whether there are different impacts for different groups who receive that intervention, or if all groups are actually being impacted the same, which is one thing to consider with effectiveness. The third thing of REAIM is adoption. So do organizations adopt the intervention? If they do adopt the intervention, are they able to do it well? Or do they struggle and there are some barriers? Trying to understand what would make an organization take up or adopt the intervention, or what might make it difficult for them to do that. Trying to measure and evaluate those questions. Fourth, we have implementation, and there are many, many implementation questions. I put 3 just to think about, but when we think back to those implementation outcomes I had at the very beginning, any one of those outcomes could be part of this, of what you're measuring. So you could answer questions of quality of intervention delivery, what barriers to delivery, and what are those costs? Because oftentimes we underestimate the resources that it takes to implement an intervention, and that can be a big barrier to and a big limiting factor to why it takes so long to get our research into practice. Finally, maintenance, which is, are these intervention effects maintained in people and setting over time? Are these organizations, are these individuals still enacting these interventions after the research has ended? Or even if the research is still happening, if it's 2 weeks or 6 months post intervention, are folks still able to do the thing you taught them? Are they still doing it once they might not be seeing as quick of results? And if they are not, how are ways that we can enhance an intervention or ways that we can measure enhancing an intervention? I'm going to show more than tell you about another example that used this. And in this example, and I will share these slides later, but in this example, we were talking about whether older adult participants of the program were able to, we want to evaluate if they were doing it. And Stepping Onto Pasando Forte is an evidence-based falls prevention program for Latino seniors. So for reach, we were seeing the number of characteristics of individuals willing to participate in the program. Who were the folks that actually registered, enrolled, and completed this program? And are they the same or different than in other programs? We looked at efficacy. So we wanted to reduce the number of falls per person during the 6 months of the intervention. Did that happen? Adoption. What are the characteristics of the organizations who took up this intervention? And can they describe any barriers or facilitators to adopting it? And this was done both by looking just at those characteristics of the community organizations and also doing some semi-structured interviews with leaders of the workshops and from the settings to see what was going well or not so well. For implementation, we were looking at fidelity of delivery of the intervention. So were they doing it as written in the protocol, or were they not? How can we measure? We wanted to measure that. And then finally, maintenance. Are the folks, those participants in the program, enacting the health behavior long after the intervention has happened? Are they still using the skills that were taught during the workshop in their daily lives after the intervention ended? And these were done with semi-structured interviews with the participants later on. So asking, are you still pausing for balance when you stand up, and seeing 6 months later if they remember that they are doing that, or if they say no, I don't have the time to really take that moment. And so really trying to understand if they're still having long-term fidelity of enactment. As I mentioned, there are so many other popular models. I put a handful here, mostly focused on ones we've talked about in short course before. But again, we have so many on our website, and there are so many things out there. Happy to discuss more at a different point. The final thing I want to talk about today before we switch over to Q&A is design for dissemination, or design for equitable dissemination, which is really what I've been talking about this entire time. So how do we design an intervention? How do we apply this lens to all stages of intervention design and testing? How do we make sure that we're involving key impacted individuals early in the process, and that we're seeking these feedback from all impacted parties or key contributors throughout the whole process, that we're looking for both those end users and the facilitators and the organizations who will be taking it up, that we're considering every single person, organization, or macro system that might be impacted, so that we can try to design our interventions early on to minimize those barriers and maximize facilitators for those individuals. Making sure that we're able to develop strategies so that we can maximize our interventions for reach, so that we're able to, going back to that beginning slide, decrease the amount of time it takes from doing research to having an impact practice, and increasing the amount of research we do that has the impact on our end users that we want to be seeing, that we're actually making an impact on health at scale. And so to do that, there's some easy ways. We really need to consider who all those key user groups are, how we can engage with them, what they need, and making sure that we bring them to the table and ask them these questions throughout the process, not just in the beginning, not just at the end, throughout, so that we can figure out how to build our innovations or develop strategies so that these interventions can be adopted, implemented, and maintained over time. It can be challenging to really gather all of the impacted stakeholders, but what we have found is by doing this early on, by really understanding the key needs of all our user groups, we are able to increase the likelihood of getting our research into practice, and increasing that speed of getting those grants to put our research into practice. So that practical, like, carrot and stick of why we do academic research is sometimes for those grants, but often for those outcomes. And both of those we are able to do more quickly when we apply a design for equitable dissemination lens. We have plenty of resources on our website about D4ED, and we'll be discussing it in some shape during our short course. But I wanted to make sure I brought it up because this is a really nice lens to bring that ties together all the things I've been talking about today. So that's all I'm going to share with you today. As I mentioned, we are now going to turn it over for Q&A. But before I do that, I do want to share just like one more plug before we get kind of deep into our thoughts for all the resources that we have at the D&I Launchpad. So most for you who are here today, you've already signed up for our DRISS seminar, but I would just encourage you to share it with your friends. And so that is the website. You can see all our future speakers that are going to be coming and giving wonderful presentations. Sign up for our short course. It's going to be amazing. We've spent so much time with our guest faculty developing content based on what we heard from past participants that they want to do to really make it engaging and apply their projects to this work. The resources that I've mentioned many times over can be found on our website, go.wis.edu/launchpad. And any follow-up questions you have, you can send, well, either to me directly, I'm sure my email is somewhere, or to our D&I Launchpad service account, which I will be checking, and those emails can be forwarded to me as well. Then finally, we're going to have a survey, and I'd really appreciate it if you filled it out. We like to make sure that we're having our content apply to those who are attending the session. And the best way I can do that is by learning what you all want. So please fill it out. Thank you.
Oops, thank you so much, Felice. This was great. I just love the way you put this together in the whirlwind tour, which actually makes sense. So we do have a few questions. There's one question in the Q&A that I'll start with, but and then Alejandra may want to elaborate, but did either STQ or Pisando Fuerte have control groups, and did they require consent?
Well, so I can answer my thoughts on this, but I'm wondering, Jane, if you at least want to talk a little bit about Pisando Fuerte in that process.
So I know with Pisando Fuerte, that was a pre-post. And the rationale for doing it as just a pre-post is that when you do a cultural adaptation, if you maintain fidelity to the key elements, then you should be able to demonstrate its effectiveness as a pre-post, but not having to do another randomized trial. So, and then in terms of consent, we did for talking to participants who were taking Pisando Fuerte, we did get informed consent for them. STQ, I'm not sure what what is it?
Striving to quit. So I've talked to Dr. Fiore about this a bit. This was one of many studies they have done about striving to quit. There were several aims. So they have done controlled trials. They have had an informed consent process, and I can share his contact information for follow-up if you would want to follow up with him as well, or we can have a separate conversation about what they've shared with me about their process. I see a question in chat related to our consultation services. So our consultation services are available for any UW affiliated folks doing D&I research. It can be in non-health related disciplines. That being said, I would say most research has an impact on health, but feel free to tell me otherwise. I am happy to, maybe one of our facilitators can put our consult request form into chat, but yes, absolutely, we are more than happy to consult with any UW affiliated person. I also should, you say namely educational research, I'll put a personal plug in that I'm by training an educational psychologist. So I came into this work because I cared a lot about what we were seeing in interventions related to education, but also the well-being of all those folks involved in the education. And I wanted to be involved in interventions that were making a difference on all those different levels of context, and then got really bought into this idea of just behavior practice change, and how can we actually create and adapt interventions so that they work better for more people and have more of an impact more quickly. So yes, it's the short answer to what you just asked. Any other thoughts, questions?
I do have one question, Felice. For someone who's pretty new, I guess, how do you sort of make your decision about what kind of model, which model to use and what's the best one? I know there seems, or can you use more than one?
It's a good question. So I'll answer this in a couple of different parts. So to answer the last question first, can you use more than one? Yes. I would only recommend using more than one if it answers your research question to do so. And so the first thing that I recommend all researchers folks who are interested in implementation science research do when they come and consult with us about how do I pick this model is really figure out what your research question is. And that really will guide how you select the model. So if you're wanting to understand context or those different determinants, then I might recommend CFIR. If you're really focused on evaluation of outcomes, I might recommend REAIM. And so trying to think through that question, what are the research questions and key outcomes that matter to me and to those who will be impacting? And that really can guide how you select your model or framework.
Great. While we are, there's another question, but first I want to just ask everyone to complete a feedback survey. As Felice mentioned, we really value the feedback, and we will put the survey link in chat. And then we'll also send you a follow-up email with a link and a request to complete the survey. And just want to give a reminder about in November, our seminar in November will feature Angie Calvin and Avery Salerno presenting on fostering healthy social media use through disseminating evidence to families, educators, and physicians via a Q&A web portal. So the presentation will provide an overview of the American Academy of Pediatrics Center of Excellence on social media and youth mental health and the interface with the Q&A portal. And they'll talk about the process of how questions are answered, challenges with answering questions, example questions and answers that are seen through the portal. So it should be very interesting. So please register and join us. So we do have one more question, Felice. Are there any resources that you know of to help us discuss D&I with non-academic community partners? The current model is helpful, but sometimes does not sound as sciencey as our partners expect from us as researchers. Great question.
It's a great question. And I'm not sure necessarily one comes to mind right away, but I'm happy to think about that and get back to you. The thing that popped into my mind right off that was more sciencey, but still pretty basic, was actually related to a conversation we had today with Danny Almiral related to who is one of our guest faculty, to something he is working on. And so during short course, I'll foreshadow that he's going to be sharing a kind of basic overlay of why and how we can use an D&I and how it differs from a traditional intervention study. But that's a good question, and I will definitely get back to you. Do you have any ideas, Jane?
You know, what popped into my mind was probably starting with REAIM, because understanding why is impact more than just an effectiveness study, and then kind of working backwards from there to understand, well, how do I make sure that I am going to have the desired impact, which I could measure with re-aim. So that, but that's a really good question, is how do you really talk about that?
Yeah, I have definitely found that in talking with community partners, I need to talk with community partners. That sending them a resource or a slide doesn't always get across like why this matters, as much as having a conversation about like the goals of implementation science and how tailoring our strategies or really understanding the context will lead to more impact for all the folks that we care about. And so really centering that in their work and why it's valued is helpful to get them to buy into our work as implementation scientists. But it's a great question. We do need some resources that we can provide to our community partners. Well, if there are any final questions, I'm happy to stay here, but otherwise, again, please feel free to follow up via email and attend our short course.
Thank you so much, everyone.
Thank you.